Assalamu alaikum. What is the key evidence upon which you can base a decision on what is the safety margin for a parotid pleomorphic adenoma? Parotid pleomorphic adenomas have some special and peculiar tumor features. They are very common. They form more than 60% of all parotid tumors, and surgical excision remains the standard form of treatment. It used to be treated in several surgical approaches. The oldest was the simple inoculation, which yields a very high recurrence rate in excess of 1 in 4 and up to 45% in some old series. The capsules of these tumor is in most cases very thin, less than 20 microns, in at least one area of the tumor. The focal absence of a capsule is found in about 50% of the histological specimens of excised tumors. Half the excised tumors had at least one part of the capsule absent. And the pseudopodia from the tumor extend beyond the capsule in about 1/4. And sometimes the tumor is also multicentric. You have several foci of this type of tumor in the gland, and the tumor lies in close proximity to the facial nerve trunk or one of its major branches in a substantial number of cases, and there is also a small risk of malignant transformation in the area between 1 and 5% within a 10 years period. In addition to simple inoculation, which ran out of favor, the other types of surgical resections for this type of benign tumor include the extracapsular tumor resection, in which the facial nerve trunk is identified together with its major divisions. The tumor itself is resected just outside its capsule with a tiny cuff of normal parotid tissue, leaving behind most of the parotid gland. The superficial parotidectomy operation comprise a formal identification and dissection of the facial nerve and all its major branches, and the resection of all the parotid gland superficial to the level of the facial nerve, including the tumor, or if the tumor lies deep to the facial nerve level, a superficial parotidectomy is carried out first, followed by resection of the deeper part of the gland, deeper to the facial nerve and its branches, together with the tumor. Each of these different resections is associated with certain complication rates and recurrence rates. Some of them are serious and some of them are less serious but more common. Of the serious complications group is the recurrences or a positive resection margin, or a facial nerve injury, particularly if it is permanent, or a diagnostic error. The more common but less serious complications include Frey syndrome, or a greater auricular nerve injury, or a salivary leak, or a seroma, or scar issues, or wound infections, or a hematoma in the parotid bed. Pooling of several studies to estimate the rate of recurrences for the different approaches by meta-analysis showed that simple inoculation would result in a 9 times higher rate of recurrences compared, for example, with superficial parotidectomy. The rate of recurrences for the total parotidectomy, superficial and deep lobes, or superficial parotidectomy, or a partial superficial parotidectomy, on average would be around less than 3%, typically about a decade after the original surgery. However, a Dutch national pathology database showed that the average recurrence rate after 20 years could be much higher at around 6.7%. Total parotidectomy, removing the superficial and the deep lobes, would have the lowest recurrence rate, less than 1 to 2% recurrence rate, compared with inoculation, which is around 27% recurrence rate, somewhere between 20 and 40%. This is a 9 times higher risk of recurrence. And these recurrences would be multicentric, as you could see, and very difficult to excise and resect completely in a revision surgery. Of the other serious complications, the facial nerve dysfunction postoperatively. A transient facial nerve dysfunction is not uncommon. For approaches like a total parotidectomy, it may be up to 60% of the cases, because that would involve the maximum stretches and injury to the facial nerve. It would be a bit less for superficial parotidectomy and much less for partial superficial parotidectomy, in which only dissection of a part of the superficial lobe is done, usually the lower part of the gland. But it is about only 11% in extracapsular dissection, and the same for inoculation. But these are transient facial nerve that would resolve spontaneously within weeks. The much more serious permanent facial nerve dysfunction would affect about 4% of patients who had total parotidectomy, a bit less for the simple inoculation. Although this is just a simple inoculation, you could inadvertently damage the nerve, and in that case the injury is more likely to be permanent than transient. It would be less for superficial parotidectomy, or just less than 2%, and a bit less for extracapsular dissection, and much less for partial superficial parotidectomy. Of the more common types of complications, Frey syndrome, for example, the incidence of Frey syndrome after a total parotidectomy would be almost 1 in 2 at 47%, much less for superficial parotidectomy at 17%, and even less for partial superficial parotidectomy, almost 10%, and almost a very small percentage with extracapsular dissection of the tumor. A very general overview of these results would set up the scene. The most conservative procedure, the simple inoculation, which is now almost obsolete, would carry the highest recurrence rate. On the other hand, the more radical resections would carry the higher complication rates. The optimum procedure is somewhere in between, which operation would ensure minimal recurrence and does not cause unnecessary morbidity. Postoperative histological analysis of the specimens showed that no matter what type of operation is carried out, there will almost always be one margin in which the tumor capsule is next to a facial nerve branch. In the UK, the most common practice is to remove these types of tumors by a superficial parotidectomy or a partial superficial parotidectomy. The argument for this is that taking a cuff of the normal gland would reduce the chance of tumor spillage by an incomplete and thin capsule. But most of these tumors, except for very small tumors at the tail of the parotid, will be near a facial nerve branch anyway, and dissection of the facial nerve branch would expose the thin capsule. Histological analysis show that this, even with the standard superficial parotidectomy or the partial superficial parotidectomy, 81% had some degree of capsular exposure. And this capsule exposure is actually more than 50% of the surface of the tumor in about 60% of the cases. It would not be limited just to one area, it would be around 50% of the surface of the whole tumor. This would give the basis for the other argument in favor of extracapsular dissection, and when possible, because the extracapsular dissection at one part up to 50% of the tumor surface would be carried out anyway by the more radical superficial parotoidectomy. Some more key evidence, this time related to the size of the tumor. We know from cumulative data of the tumor size is that the average pleomorphic adenoma tumor would be around 3 centimeters. Some of them could be much larger, of course. But if you relate this size on one side to the facial nerve dissection on the other side, you would see clearly that facial nerve dissection in green is almost always carried in bigger tumors, tumors above the size of 3 centimeters. You would always find a branch of the facial nerve in close proximity requiring dissection of the capsule itself. And if you take this one further step of the size of the tumor against the recurrences, you would also see the same pattern. Recurrences would happen with larger tumors, mainly the tumors that required facial nerve dissection of the capsule of the tumor. When we take the analysis one more step further to see the relation between the tumor size and the safety margin, on looking at the plot of the safety margins, you could see that the vast majority have no margin at all, have a zero margin at one point of the circumference, and that the maximum safety margin would be in the area of about maybe 2 centimeters or so, but most of them would be in few millimeters or zero. When you relate the margins to the tumor size on the x-axis and the margin on the y-axis, you would see that the largest tumors, those above 4 centimeters, have virtually no margins at all, and that at least a third of the tumors had no safety margins at all. These are the larger tumors that are around 4 centimeters or in excess of 3 centimeters plus. Only very small tumor sizes would have any significant safety margins of normal parotid tissue. The main thing is that your goal is an intact capsule and a negative tumor margin. You shouldn't be seeing any actual spillage of the tumor into the salivary tissue. This is much more important than an arbitrarily wide cuff of normal salivary tissue around the capsule. How much of this tissue would be resected with the tumor depends on things like the tumor size itself and whether it is in the superficial lobe or the deep lobe, and whether a facial nerve branch is in close proximity here or not on the other side. But the main thing is that if the capsule is intact and there is no spillage of the tumor cells into the parotid bed, then this is much more important than having a thick cuff at one point and an exposed capsule or ruptured capsule at another. So what does margin actually means in parotid pleomorphic adenoma? If we follow the routine of placing ink dots in the resected specimen just outside the tumor itself, then a clear margin is when a negative margin is when the tumor cells are not in direct contact with the ink dots in histological examination. Obviously, there is a rupture of the capsule in here with the spillage of the content of the tumor, and that's a positive margin. The main goal would remain an intact capsule that is not touching the ink, even if it is in close proximity to it. 5 millimeters margin was often quoted in textbooks as an accepted margin, but it is often impractical in parotid resections because of very close facial nerve anatomy. Many groups now use 1 millimeter as a working cut-off point for close versus negative margin. 1 millimeter would tell you this is close margin but not negative, so long as it's not in contact with the ink markings. And the management decisions are guided more by the margin status, whether it is negative or close or positive, and the intraoperative events like spillage or capsular tear, than by attempting to keep 5 to 10 millimeters cuff of normal parotid tissue as quoted in some textbooks. Now back to the outcome of the various types of resections for the parotid, and omitting the inoculation because it's no longer widely practiced. You could see the pattern we have discussed earlier, that the recurrence rate for the tumors is not necessarily related to the size of the resection. In fact, it can be a fewer percentage of recurrence in the smaller resections compared with the more radical superficial parotoidectomy or total parotoidectomy. Whereas you can see also that the incidence of either transient facial nerve palsy or permanent or Frey syndrome is lower in these operations, the extracapsular dissection and the partial superficial parotoidectomy, compared with the more radical superficial parotoidectomy and total parotoidectomy. Extracapsular dissection removes the tumor with a thin cuff of the salivary tissue around it, but only in selected cases. In patients who have small tumors that are mobile in the superficial lobe and less than 3 centimeters in size, and they must be away from a facial nerve trunk and its major branches that should be exposed earlier in the operation. On the other hand, partial superficial parotoidectomy, in which only a part of the superficial lobe, in this case it is the inferior part, which is here, and was resected. The upper part of the gland, the superior part, is left in situ after identifying the facial nerve trunk and the lower branches of the facial nerve trunk. The recurrence rate for these two procedures are comparable and have lower short-term morbidity in terms of facial nerve transient weakness, or also things like shorter operation and shorter hospital stay. So these two operations are becoming more and more in common use because they can provide a very satisfactory recurrence rate and also very satisfactory complication rates. So what does that mean in practice? It means that the primary goal in these parotid resection is to preserve the tumor capsule. At a negative margin away from the dotted ink is much more important than having a several millimeter thick safety margin in other places of the gland. The capsule rupture, which sometimes happen, should be avoided if that's at all possible, because this is the single most important event that is very strongly related to recurrence. But if it is ruptured, this should be documented, and then one have to consider whether to do a wider resection during the same operation to remove all the areas of the salivary gland that has been soiled with the tumor contents, or to discuss this with the patient and counseling him after the surgery on the need for either a re-excision of the salivary gland remnants or a longer follow-up and a discussion about the possibility of tumor recurrence and re-excision, and in selected cases where there is already a recurrence or a high risk of it, whether adjuvant radiotherapy for this benign tumor may be considered. The operation should be tailored not only to the tumor size and site and relation to the facial nerve, but also to factors related to the patient, like his age, for example, and whether he can tolerate a more radical resection or do with radiotherapy. The other factor is that smaller tumors, less than 3 centimeters, that are mobile in the superficial lobe and away from the major nerve branches, extra capsular dissection can be an appropriate choice, followed by, if needed, the partial superficial parotidectomy. Larger tumors may require a formal superficial parotidectomy, and if they affect the deep lobe or are multifocal, then a total parotidectomy may have to be carried out to ensure the negative margins. The margins should be actually very clearly documented and defined by ink dotting, and this would help in clarifying whether the capsule is coming close to the tumor but not on the ink. In that case it would be negative, or if it actually transgress the line of the ink dotting, which will then be positive. A 1 millimeter margin is often used as the cutoff for close proximity to the ink in salivary surgery. 5 millimeters is probably a bit too optimistic and not very practical, because facial nerve branches would be quite close to one point or the other if the tumor size reaches anywhere around or more than 3 centimeters or more. And close but still negative. Close means that the tumor content is still contained within a capsule, and about 1 millimeter from the ink dots can be actually managed conservatively without a need for further intervention. These key evidence have some limitations. Some of these limitations relates to the duration of the follow-up period. As we have seen, most of the cited follow-up periods were within 10 years from the date of the surgery, but the Dutch study showed that the recurrence rate could be almost doubled if you follow up the patient for 20 years, for example. The other thing is that these results may be subjected to a selection bias, because many of the series, including extracapsular dissection, were on patients who had small and superficial tumors. The results therefore would be expected to be better in terms of recurrence rate and other complication rates. Most of the data are retrospective or from single centers. That's again another form of selection bias. But recent prospective work and some of the systematic review, including meta-analysis, are actually encouraging for both the extracapsular dissection and the partial superficial parotidectomy operation. The definition of the certain complications would also differ, because in some cases transient facial nerve, for example, dysfunction was diagnosed not only clinically but also electrophysiologically, which detects higher incidence of transient facial nerve injury or dysfunction related to other studies, depending mainly on the clinical diagnosis. In conclusion, the partial superficial parotidectomy, which is in other ways a hemi-superficial parotidectomy, usually based on removing the lower half of the superficial lobe, is as safe as the standard superficial parotidectomy, removing both all the tissues superficial to the facial nerve. Extracapsular dissection is a required step in about 1/3 of the cases, no matter the type of the resection. Even when you're doing the most radical of these resections, total parotidectomy or the formal superficial parotidectomy, extra-capsular dissection of the tumor, of this big tumor, would be carried out in at least the third of the cases. And a facial nerve branch, a major branch of the facial nerve, would need to be dissected of this bare capsule in almost all cases of total parotidectomy or revision parotid surgery, and all tumors of a size more than 4 centimeters. These are some of the key citations used in this presentation. By this, we come to the end of this presentation on what is a safety margin in parotid surgery for pleomorphic adenomas. Assalamu alaikum.